So, good morning and warm welcome to the day 2 symposium. I hope yesterday's activities were quite useful to you, and I can figure out that many of you are so much charged up to hold that Agilicis Pro. You must be kind of restless to show that lead into that septum. I think that was the purpose of this whole symposium, and it is really very gratifying that all the efforts by those experts have borne the fruits. Today, before we get some more audience, I would like to introduce to you one of the greatest basic researchers as well as a practicing electrophysiologist of Indian origin, Dr. Gaurav Upadhyay. It had been our endeavor to get him to the country in the last 2-3 conferences of the IHRS, but he had been busy. But he had been always encouraging and very generous whenever we asked his help, his guidance. And many a times online he had taught us so many things. Recently we have had Cardiology Society of India Rhythm Council. He was a faculty, and his lecture inspired several of the young electrophysiologists. Appropriate to this symposium, I'm going to be displaying the video recorded presentation. He generously has, I'm sure he had taken so much of a time to prepare the talk, and he had sent in a recorded version. So on behalf of all of you, I express my gratitude to Dr. Gaurav Upadhyay for being so very kind to allow us to hear his recorded presentation on a very serious issue with respect to the conduction system pacing. And yesterday we have been discussing, could CSP just replace the CRT, or are there any indications for the conventional CRT? So he's going to be discussing with us the various patterns of the left bundle branch block, and any certain pattern is more indicative of a better result with the conduction system pacing, or is there any pattern where CRT still is the treatment of choice, or are there any patterns where the CRT needs to be optimized with the conduction system pacing? So I think yesterday's all those discussions, debates, almost arguments what we had yesterday, I think his presentation is going to provide answers to all those questions. That's my belief. So again, on behalf of all of you, I thank Dr. Gaurav Upadhyay for providing his lecture. So let's start listening to his lecture, please.
Good morning. It's a pleasure to be here with you today to discuss left bundle branch block patterns, implications for choosing patients for conduction system pacing to deliver cardiac resynchronization therapy. It is a real honor to join the Arrhythmia and Heart Failure Academy of the Madras Medical Mission, and I wish you the very best for your meeting. I appreciate very much the invitation to present. Let's begin our discussion today with a review of the ECG. This important technology was first developed in 1901, with the current 12-lead format actually standardized in 1954, so now close to 70 years ago. The first recording of an ECG is shown here by Einthoven of a human, but in fact, the very first recording it's reported was of his pet, Jimmy. Now, some of you may be looking at this image and be wondering, is this simply another example of fake news? Well, to this, we can look at the data. Here, the data is of the image itself. This is a photograph of a bulldog in 1901. This is another photograph of a bulldog in 2021. Note that the bulldog today is shorter, closer to the ground, has a wider neck, has more skin folds covering its eyes, has more jowls, and indeed has a shorter tail. These are all favorable characteristics that we have selected for with selective breeding. Now, you can see this in an instant because your signal processing power of your brain is integrating numerous sets of information. This is very similar to how we look at EKGs. Let's explore some examples. Here we see the example of right bundle branch block, and here is another EKG of a left bundle branch block. That pattern is immediately visible to many of us looking at the images. The reason for this is that we quickly pick up on the fact that right bundle branch block has an R prime pattern, whereas a left bundle branch block has a QS pattern in V1 or a notched broad configuration in lead 1. Importantly, patients with intraventricular conduction defect, which is not specific, are simply those patients who do not meet the criterion for right bundle branch block or left bundle branch block. When examining a bit closer, a patient with an ECG of left bundle branch block has certain key characteristics. A QS pattern in V1, V2, and V3 is often present, as well as notched complexes in leads 1, AVL, V5, and V6. Importantly as well, some patients with left bundle branch block pattern will demonstrate complete correction with conduction system pacing, here with His bundle pacing, with significant narrowing of their QRS. And that begs the question, what is the mechanism? The importance here is that left bundle branch block pattern does not necessarily mean left bundle branch block. Where patients who benefit from conduction system pacing require, it's a requisite that left bundle branch block be present, there are other patients in whom conduction system pacing may not benefit, and it is valuable to try to differentiate the two when selecting for cardiac resynchronization therapy. The ECG pattern of left bundle branch block is heterogeneous. One commonly used definition was put forward by the ACC-AHA-HRS in 2009 and uses the QRS width as well as notches or absent Q waves and R wave peak times as a means to determine whether left bundle branch block is present. Some of these patients have true left bundle branch block, here shown on activation mapping done by Derval and colleagues in 2017, and they differentiated this from patients with nonspecific interventricular conduction defect. Those patients are less likely to derive benefit from CRT. When other investigators have tried to examine different criterion for left bundle branch block, they noted that irrespective of what criterion is utilized, there can be differentiation in performance for delivering cardiac resynchronization therapy. This is with biventricular pacing. Now, biventricular pacing may have some ability to address intact Purkinje activation, but is really best able to treat patients with left bundle branch block in which there's no presystolic Purkinje activation. And that's really what we are trying to differentiate, is patients who have block versus no block. This raises a more fundamental question, which is what is left bundle branch block? Is it due to the longitudinal disassociation of the His bundle? Are there predestined fibers, in which case we should see intra or interhisian disease? And this concept was first put forth in work in 1978 by El Sharif and colleagues, who argued that delay at the His bundle was the cause of left bundle branch block, and this could be corrected with His pacing. Other theories that were put forth included left bundle conduction delay, so further down in the conduction system, or due to source sync mismatch overcome with the current load. And perhaps a simpler concept was simply the fact that left bundle branch block might be due to block, and it could be leapfrogged with a virtual electrode. Indeed, that very simple, elegant concept was first put forth in 1977 by Narula, who in this famous illustration actually pointed to where the block may actually be present. And this elegant concept, of course, needs evidence. We hypothesized that interhisian delay between the right and left His fibers was the underlying mechanism of left bundle branch block. So we actually felt that perhaps longitudinal disassociation may explain what we see on the surface 12-lead ECG. We explored this with high-density multi-electrode mapping of the left septal conduction system. This was done in patients both referred for His bundle pacing implant at the time to prognosticate on left bundle branch correction or during substrate mapping for VT ablation. Our experimental setup involved the use of a quadrupolar catheter on the right side and a duodecapolar catheter on the left side of the septum delivered by a retrograde aortic approach. Here's an example of an intracardiographic image in which we have a multi-electrode catheter here on the right side of the septum. And here's another catheter being shown on the left side. So what we're interested in here is the left septal recordings. And we felt that this could give us the answer with respect to the mechanism of left bundle branch block. The conclusion of our intracardiac analysis was that when evaluating left septal recordings, we found that patients with normal narrow QRSs demonstrated intact presystolic Purkinje activation prior to local ventricular electrogram activation, that patients with complete conduction block and left bundle branch block pattern demonstrated abrupt discontinuous activation, so abrupt block, of their His Purkinje system, here shown in a patient occurring very high at the left-sided His fibers. There is no conduction now into the left bundle, and there is dysregulated activation of the ventricular electrograms, and the block is high enough that an atrial electrogram can still be recorded. Because we know that the left-sided diagnostic catheter, the duodecapolar catheter, is on the left interventricular septal surface, we speculate that this block is in the left-sided His. This is in marked contrast to patients who demonstrate intact Purkinje activation and intraventricular conduction defect. Some of these patients may demonstrate all of the criteria for left bundle branch block pattern, but indeed have no actual block. They have intact activation of their presystolic Purkinjes. Returning to a question that we had earlier, how could the QRS be corrected by His bundle pacing? Here we performed right-sided pacing via a quadrupolar diagnostic catheter, and we note that there are high-frequency signals just after the local ventricular electrograms recorded on the left septal surface, and that these Purkinje potentials we speculated or hypothesized are then recruited with increasing output. So we're able to recruit these Purkinje potentials now before the QRS and are therefore able to recruit latent Purkinje to narrow QRS. Another nice mechanistic example of conduction block was in this patient who demonstrated a wide QRS at the start of the left-sided duodecapolar recording, and at pacing at the site of the left-sided block, we noted that for 1 beat there was narrowing of the QRS, and when examining those potentials, what we saw was actually a split His now noted on the left-sided recording, but that was only present with a narrow QRS. Taken one step further, what we see here is that a split His, which is an example of interhisian conduction delay, is actually associated with a narrow complex, and that's because conduction is still occurring. There's not marked delay within the His. Instead, it is only those patients who have complete conduction block where we find that there is no conduction down the His Purkinje of the left side. Therefore, the disease is not in the left bundle, it is before the left bundle. Another important implication of these findings is that patients with intact Purkinje activation cannot be corrected. Whether pacing from the right side or the left-sided His, there is no correction of these patients. The implication, of course, is that conduction system pacing cannot correct or substantially benefit patients with intraventricular conduction defect. When evaluating all of our patients, what we found was that left intrahischian block was present in 46%, and that QRS correction via His bundle pacing was achievable in the vast majority of these patients. That there were some patients who demonstrated left bundle branch block, which was slightly lower, where an atrial electrogram could not be recorded. And in these patients, His bundle pacing was less likely to achieve QRS correction. And up to a third of our patients demonstrated intact Purkinje activations, although meeting criteria for left bundle branch block pattern based on surface QRS. When thinking about modern therapies, patients who have left intrahischian block could reasonably be considered for His bundle pacing for CRT, although there may be threshold problems with His bundle pacing over time, and that is certainly meritorious of further discussion elsewhere. Left bundle branch area pacing is a promising new approach to address patients with more distal conduction block, although the criterion required to demonstrate left bundle branch area pacing is occurring do need further validation and vetting. Traditional biventricular pacing or hybrid strategies, as you'll hear about later in today's meeting, may be particularly useful for patients with intact Purkinje activation as the source of their block, or patients with mixed conduction block and intact Purkinje level block. Now, what criterion could we use to determine whether complete conduction block is present? Because these patients are the most likely to benefit from conduction system pacing. One might examine the QRS width, but that actually was not particularly helpful. The presence of QRS notching, however, on the other hand, was present in nearly all of the patients with complete conduction block. We put forth, based on our intracardiac electrogram analysis, new criteria, including the absence of an S wave in V6 or R wave greater than S wave in V6, and a time to notch of greater than 60 milliseconds and leads 1 AVL, V5, or V6. So these are really modifications of the Strauss criterion. We evaluated the performance of these novel criterion in a cohort of 75 individuals in whom conduction system block or intraventricular conduction delay, as well as response to His bundle pacing, could be assessed with intracardiac recordings. What we found was that of those novel criterion, that the time to notch in particular demonstrated favorable performance at distinguishing patients with complete conduction block as well as those more likely to benefit from conduction system pacing. We also sought to examine the performance of these criterion in other data sets, and here we were able to obtain the original EKGs from the reverse study, and we found that the use of these novel criterion were better able to distinguish remodeling after cardiac resynchronization therapy, even using a traditional biventricular approach. Importantly, there is also a trend towards greater benefit, both with respect to time to heart failure, hospitalizations, or death, with the new model. Now, let's try to apply some of these criteria to 12 leads for patients. When looking at this 12 lead, does this reflect left bundle branch block or interventricular conduction defect? There is notching present, both early and late notches, and the QRS is very broad. Interestingly, for this patient, there was presystolic Purkinje activation, and it did not reflect complete conduction block, although highly suggestive based on the surface QRS. This reflects the limitation of any surface ECG-based criterion. What about this patient, who also demonstrates a wide left bundleoid configuration with significant notching noted in 1 AVL as well as V6? Is this left bundle branch block or IBCD? Well, this individual underwent His bundle pacing for QRS correction because complete conduction block was present, and during His bundle pacing, we see correction of the QRS. There's selective QRS correction, and here's selective without correction, and yet there's residual delay of 153 milliseconds versus a normal QRS less than 120 milliseconds, which reflects underlying delay which is non-specific in nature. So this is a patient with mixed conduction block. Correcting left bundle branch block may unmask underlying IVCD, and indeed these patients may uniquely benefit from a hybrid strategy of conduction system pacing integrated with biventricular pacing. To conclude, interventricular conduction defect is a diagnosis of exclusion and is often due to a combination of fibrosis and hypertrophy, but is nonspecific with respect to the ECG pattern. The Strauss criterion does improve classification of patients with conduction block, allowing us to better select patients for CRT. And time to notch of greater than 60 milliseconds is a valuable tool that you can consider using at the bedside when evaluating patients for CSP CRT in particular. Limitations, however, remain with respect to surface ECGs, particularly when scar is present, and intracardiac mapping has utility in understanding the level of block, although certainly not required or advocated for all patients. When evaluating a patient for CSP CRT, however, at least knowing that there is a notch and that the notch is late would increase the probability of a favorable outcome. However, if conduction is not being corrected with conduction system pacing, our suggestion would be to go to a traditional biventricular system or a hybrid system. Thank you again for the tremendous opportunity to join you for your symposium, and I hope that you have a wonderful meeting. Good morning. It's a pleasure to be here with you today to discuss left bundle branch.
No, I think a very elegant presentation which tries to distinguish between the block which may be present in the conduction system versus a delay that may be happening later in the myocardium. So he has tried to identify a Purkinje system block which would meet a conduction system block and see if that correlates with the ECG. So any delay that is in the initial part of the QRS reflected as slurs or a delay in the intrinsic oil deflection is considered as a delay in the conduction system and therefore likely to be correctable. So he has numbers of intrinsic oil deflection which is more than 60 seconds, and elegantly with the decapolar mapping catheter or duodecapolar mapping catheter he has shown that there is a block at different levels in the Purkinje system, and that would help us. Although practically we wonder whether this can be done as a pre-operative thing to counsel patient as to what you are going to do. That may be difficult, but still it is an elegant mechanistic study to, even on table to take a call preemptively whether you will put the left bundle lead first or the CS lead first. For example, if you see a block like that, you would be encouraged to put a left bundle lead first, evaluate the QRS and then decide whether you need. At the same time, at the end, he does point out to the limitation that there is always a possibility of a mixed block. And these are the various limitations and understanding that one must keep in mind when one is deciding to do a LBB area pacing only for CRT or wanting to add a bi-V lead, or is convinced from beginning that the CS lead should be first because the delay is peripheral. So you put the CS lead first, you put the RV endocardial lead, you still see a wide QRS, you know that it's a mixed block and would be helped by doing a left bundle area pacing. So I think this mechanistic study helps us to think online as to what would be the sequence of the leads, whether the second lead should be a CS lead or whether the RV endocardial lead should be a left bundle area pacing lead. It's a valuable, I think, mechanistic study.
I think you really very well summarized the points. Well, I think ECG-wise, it may not be really, time is not yet ripe. On the basis of the ECG, you will choose your approach. Maybe on table, only on the result, depending upon the QRS morphology, you may have to be selecting the conventional or only the CSP or optimized. I think there's a lot to learn. To extend whatever he had been giving his impressions about the ECG criteria to decide where is the block. There are experts like Tan Boon who considers CSP in heart failure has a tremendous role. When we listen to his talk, I think he's going to be talking about some of the morphological characteristics when during your talk. So, but before that, learn about something more about the conduction system from the point of view of imaging. So we have our ex-colleague, Dr. Deep Chand, the bright electrophysiologist who had trained in Australia, Canberra, who recently had joined back India, and he is working as a senior electrophysiologist at Kaveri Hospital, Chennai. So he's going to be talking about, sure. Okay, so anyway, Deep Chand is going to be talking about the role of imaging, if at all, if there's any, in considering a conduction system pacing. I think he's going to be telling us some echoes or some other imaging modalities. So you wanted to add one more point?
So if one were to do some kind of a conventional EP study before making a guess as to what should be the lead that should be put first and things like that, one would put a catheter, such a duodecapolar catheter along the left septum to evaluate the conduction system on the left. One could also put a decapolar CS catheter deep in the CS so that one records the lateral LV wall pacing, and one could see whether the block is happening in the conduction system on the left, what is the time between the Purkinje or the left ventricular endocardial activation on the septum and the lateral wall endocardial activation, and see how long these times are. I mean, it could be a thing for study or a rough guess at least. And the third thing is one could pace the his and see if one can narrow the QRS and then come to the conclusion whether it's a central delay or a myocardial delay. So one can do such kind of a simple EP study before, choosing the lead and saying whether you require one lead or two lead to achieve a CRT.
See, from the practice point of view, we should make conduction system pacing as simplistic as possible. Yeah. Look for the results on table with respect to the QRS morphology and some certain other criteria with respect to the electrograms. We should be making it more. These are all investigationals. So the experts with their research will guide us. How do we go about it? Now let us hear Dr. Deep Chand about the role of imaging in conduction system pacing.
A very, very good morning to all. It gives me immense pleasure, privilege, and honor to be here at my alma mater. This time for the Conduction System Pacing Symposium. Thank you very much, Dr. Ulhas, for giving me this wonderful opportunity to be here. So I'm going to talk about imaging in conduction system pacing. Specifically, it is cardiac CT imaging. It's not that we routinely use CT scans post-conduction system pacing or pre-conduction system pacing to get any info in details. But this talk is about two studies till now has been published with respect to trying to understand if and what insights we have got to learn from CT scans post-conduction system pacing. As Dr. Gaurav Upadhyay had shown in his presentation previously, we are in no mood to bin his bundle pacing, especially when it comes to correction of left bundle branch block. His bundle pacing is always up in our sleeves, and still we are exploring the options, how to optimize his bundle pacing for various clinical scenarios. Very much in line with the Dunning-Kruger effect, the more we are practicing conduction system pacing, the more we are exploring the options, the more we understand the anatomy of the conduction system axis. We understand that the conduction system axis is highly variable from person to person, from individual to individual. However, there are certain predictable landmarks that we have been trying to exploit so that we achieve reasonable outcomes. The question is, how do we improve upon our failures and try to achieve a 100% outcome on table and long term? Cardiac imaging goes hand in glove with electrophysiology, but as far and as long as conduction system pacing goes, we are still looking out at possible options when we have a proper cardiac imaging tool on table, so that we can add anatomy guidance to the electrophysiology guidance that we can obtain with the signal mapping. With respect to this, there are two studies, one from Dr. Vijayaraman's group, who had explored cardiac CT post-conduction system pacing, and that was in the His bundle pacing group of 51 patients. And the other one was from the Australian National University, where my close friend and colleague, Dr. Abhilash, along with Dr. Rajiv Kumar Pathak and myself, were working on trying to get more insights into the CT scans of these patients who have had conduction system pacing and trying to correlate with the lead parameters. There are many anatomists who had come out and who had described greatly the course of the conduction system axis. But with respect to conduction system pacing, that which has become a gold standard or reference article of late that we are trying to refer to is that from Cabreras. What he had highlighted, he had looked into, was the location of penetration of the AV node into the membranous septum. So remember, when the AV node penetrates the membranous septum, that's the start of the His bundle. So basically what he was looking at is the location of the His bundle from the right side of the heart. So the site of penetration of the AV bundle into the membranous septum with respect to the Cox triangle is what he was trying to explain. As shown on the left side of the office, this is a schematic again drawn by my colleague Dr. Abhilash, adapted from Cabrera's paper. So where the His bundle, or the point where the His bundle is locating within the Cox triangle, is placed much more inferiorly. This was found in 40% of the hearts dissected by Cabrera, and it found that 40% of the hearts, the His bundle starts much inferiorly in the Cox triangle. And that's when it tends to be surrounded by so much of dense, fibrous, and connective tissue. And hence it becomes very difficult to overcome the conduction or the connective tissue and pace the His bundle. But at times, when we have very easily reachable His, it's mostly the places when the His is superiorly located at the apex of the Cox triangle, as shown on the right side of the figure. What he termed as the superior His bundle, superiorly placed His bundle at the Cox triangle, which is the ideal location where the AV node translates into the His bundle. Then we have another anatomist in 2005, again an article which we frequently reference to. After the penetration of the AV node into the membranous septum, where it translates or starts as a His bundle, and before it bifurcates into the right and the left bundle branch, the course of the His bundle was what was highlighted by Kawashima. That was in 2005. So this course of the His bundle, according to the dissected hearts that he had, majority of which is 46% was type 1 he described, when the course of the His bundle or the penetrating portion of the AV bundle otherwise is at the junction of the membranous and the muscular septum. So it is the junction of the membranous and muscular septum where this His bundle traverses. It is surrounded by a thin wheel of atrial myocardium in 46%, but then a significant portion, up to 28% of the patients, where it is surrounded very thickly by the muscular septum. Again, the important thing to note here is, even so, if it is very thickly surrounded by the muscular septum, at the point when it starts penetrating the muscular septum, it is close to the junction of the membranous and muscular septum. So it is very much close to the junction of the membranous and muscular septum that the His bundle penetrates. And then, of course, during the course, in few patients, gets surrounded so much by the muscular septum. And of course, that is the 21% of cases where we found that His bundle is naked. It's not surrounded by myocardium or not much of connective tissue there. It's just on the surface of the heart. So keeping in mind this anatomy, let's look into the two studies which explored the cardiac topographic imaging options and the insights that we got from these studies. The image His bundle pacing study from Dr. Vijay Raman's group, which talked about 51 patients with His bundle pacing. So what they do with the CT scan, what they did with the CT scan basically was try to understand where the tricuspid valve plane was. That was sort of an approximation that they had, where the tricuspid valve plane, which was derived with a number of parameters again, with a number of surrogates again. But the outcome of this study was much of the His bundle pacing leads, much of the His bundle pacing lead tips were on the ventricular aspect, distal to the tricuspid valve plane. Yeah. It was only a few, select 11 patients of the 51 patients who had the lead tip on the atrial aspect of the tricuspid valve plane. But irrespective of whether it was on the ventricular or atrial aspect, contrary to the notion till then that selective His bundle pacing can be achieved only on the atrial side, this study came out with the finding that selective His bundle pacing could be achieved irrespective of the relation to the tricuspid valve plane. And then, of course, as we all know, 88 and 83%, as in this, was the acute and the long-term success rate of His bundle pacing. So we are more interested in to understand what was happening to the patients who have long-term rise in His bundle pacing thresholds. And again, an important finding from this study was whether you place the lead on the atrial aspect of the tricuspid valve plane or the ventricular aspect of the tricuspid valve plane, it did not matter. Chronic rise in His bundle pacing thresholds was not related probably to whether it's placed in the atrium or it's in the ventricle. But then there could be n number of other parameters, but at least we have, this study helped us in telling that probably not the location of the lead tip that helps us in understanding the chronic rise. It's not that. Around the same time that we were working at the Australian National University with patients who had His bundle and left bundle branch pacing leads, we had also derived some important insights into the failure of His bundle pacing leads and into the failure of left bundle branch pacing leads in these patients if it fails. So what could be the parameters for failure? So what we were looking was a bit different from Dr. Vijay Raman's group. In the CT scan, it's very much possible to delineate the septal attachment of the tricuspid valve leaflet. So very much in line with Cabrera's anatomical dissection, the point of attachment of the septal leaflet to the interventricular septum is what basically defines a right atrium from the right, differentiates RA from the right ventricle. Another important emphasis on conduction system pacing that we found should be rather on the membranous septum and the muscular septum. As we have seen from Kawashima's diagrams on the dissected specimens, it is this junction of the membranous and the muscular septum that is the highlight. If you could get to the junction of the membranous and muscular septum, that's when the success rates could be the maximum, irrespective of whether you're in the right atrium or in the right ventricle. So keeping this in mind, trying to delineate the septal attachment of the tricuspid valve leaflet and the attachment to the membranous and the muscular septum, we measured different parameters. These were the important parameters: the chamber of location of the lead tip, distance from the hinge point of the septal leaflet, again which Cabrera keeps on emphasizing in his manuscript. The hinge point of the septal leaflet is where the apex of the Cox triangle, which defines the apex of the Cox triangle, the distance from the junction of the membranous and muscular septum, the depth of penetration into the septum for the left bundle branch pacing leads, and correlation of these with the acute and the long-term lead parameters. one important finding from this group of patients was that 70% of the patients did not have an interventricular portion of the membranous septum. So the membranous septum, as we all understand, we have studied anatomically, has some atrial aspect and a ventricular aspect, but then 70% of the patients do not have a ventricular aspect of this membranous septum at all, which means the septal attachment of the tricuspid valve leaflet, that's exactly where the muscular septum starts. And this was exactly what Cabrera also had shown in his dissected specimens, that 60% of the cases he found out that did not have this interventricular portion of the membranous septum. That was absent, just absent. It could highly depend on the delamination of these tricuspid valve leaflets during the embryological evolution, but then this attachment of the septal leaflet defines the interventricular and the atrial aspects of these membranous septum. As shown in this dissected specimen, this is where the tricuspid valve plane is, and all the membranous septum is seen on the atrial aspect, not on the ventricular aspect. And in the paper, we found out, in this paper, when you define the tricuspid valve as the septal attachment of the leaflet, 85% of the selective His bundle pacing cases, the lead tip was in fact proximal to the location of the septal leaflet. It depends where you locate the tricuspid valve plane, but much of this location is proximal to the septal attachment of the tricuspid valve leaflet. When you look at the failure, let me go through the failure rates. The one important parameter that we found which contributes to the failure of His bundle pacing is this distance of the lead tip from the membranous to the muscular junction. So to highlight, the target should be the junction of the membranous and the muscular septum. There could be different ways in which imaging can help us to reach that particular location, but the target should be the location between the membranous and the muscular septum. This is one particular case where the lead tip was located a centimeter away from the junction of the membranous muscular septum, and the patient had chronic rise in His bundle pacing thresholds, leading to lead revision. And this is another patient. The patient had a non-selective His bundle pacing on table, acceptable parameters on table, and down the lane, the patient had failure of the His bundle pacing lead. And again, looking into it, it was far away. The location of the lead tip was much far from the junction of the membranous and the muscular septum. So the way to reach this membranous and muscular septum, there could be various ways. Imaging has to be the way to go. At present, we are relying heavily on the His bundle pacing signals, on the His bundle signals. And there should be an additive component of anatomical imaging. It could be in various forms. Cabrera had highlighted that right atrial angiography could be a simple measure that one can use to get to the apex of the Cox triangle, that is the hinge point of the septal leaflet. But then electroanatomical mapping could also be explored. Dynamic CT on table. There are labs, Philips labs, which are equipped with dynamic CT scans, which can help us to get to that membranous and muscular septum as well. But these are all investigative, and we are still looking out for the best tool in addition to hunting for the His bundle pacing signals. And as long as this left bundle branch area pacing goes, of course, we have a wider target. We have a wider target in contrast to a narrow target of the His bundle. Then we know we are dealing with the broad left bundle branch, which again trifurcates with a sheet, like a sheet anchor there on the left side of the septum. It is possible to reach the left bundle branch as such, and it's also possible to capture the left posterior vesicle selectively. It is also possible to capture the left anterior vesicle selectively. But capturing the left anterior vesicle might not be that easy because of the course of the left anterior vesicle, which is relatively thin than the other vesicles. But then, of the various parameters that could define success in left bundle branch area pacing, one important parameter could be the depth of penetration into the septum. The septum could be thin or it could be multiple millimeters thick, but the depth, the percentage of penetration in the septum could be an important parameter. And what we could find from our study was the depth of penetration. We could come around this value of 70%. So if we could reach a penetration of more than 70% into the septum at end diastole, as measured in the end diastole, and we could capture at acceptable parameters and acceptable outputs the left side of the fascicles. So is it game over for his bundle pacing? Definitely not. It just needs a change in strategy. We have been relying on the his bundle pacing signals, his bundle signals that we've seen during the conduction system pacing. We need to rely on additional parameters, knowing that we are dealing with a narrow target and a tough anatomy in hand. I think anatomy or tools that could aid anatomy, it could be angiogram, or it could be a CT scan, or it could be an on-table echo, or anything that could help us in reaching the portion where we need to target, which, as I had mentioned, is going to be the junction of the membranous and the muscular septum. That will help us take this field forward as far as his bundle pacing goes. And there are a lot of unknown determinants in left bundle branch pacing. Again, image guiding penetration of the septum could be considered as an important tool. Contribution, we do not know the contribution of the thickness of the septum or the fibrosis of the septum to the failure rates. Tools and techniques are evolving. Stylet-driven leads versus exactly what this symposium is about, whether we're dealing with stylet-driven leads versus the lumen leads, what gives us a better support, and which select group of patients we can use one tool, prefer one tool over the other, so that we can define success on table. Thank you. Yes, sir.
Are you willing to take a follow-up CT study with the left bundle pacing in the same way to understand how much penetration is required to?
Yeah, of course, sir. Of course, we know the parameters and the way we went around looking at these parameters. It would be great if you can look to. There are particular views that we use to identify the depth of penetration and things like that. So yes, sir, for sure. Yes, yes, exactly. This will.
Yeah, so that may lose conduction capture or may continue to do so if that remains the same despite remodeling.
Exactly. Yeah, this will be again an important parameter that we can look into. Yes.
One question, Deep. You told that the septal leaflet, usually your all leads were above the septal leaflet
Yes.
mostly when you
Yes,
studied.
for the his bundle pacing.
Correct.
Yes.
So does it have any implication on the movement of the leaflets, or did you find any TR in these patients? How
No,
much?
none of the patients had tricuspid
Okay.
regurgitation.
So usually it doesn't matter,
It doesn't
even if
matter.
you pin it into the
Yeah,
septum.
it doesn't matter. That was the same, I mean, the way the Dr. Vijayaraman's group described the TV plane was different, but irrespective, it's the same thing. It does not matter where it is. But then eventually the on-table his bundle pacing signals, on-table parameters is what matters. Septal leaflet, probably because it's the smallest of all the three leaflets, and probably it's there at the hinge point just like an apex, and probably it's, the hinge point is a commissure. It's a junction of the anterior and the septal leaflet. It's not the septal leaflet as such. So that's the reason probably we are getting away without seeing much of these TRs.
And method of doing, whether you come from the RA down or come back from the RV, does it change in your this thing? Outcome?
We have not seen tricuspid regurgitations at all with his bundle pacing leads as far as my limited experience goes. My routine practice is to drag it from the right ventricular outflow tract.
Thank you.
Dr. Tan, do you consider any kind of imaging before the implant? Apart from just a routine echocardiogram, not necessarily from the point of view of subtle morphology. Anything specific? You really care for any imaging before you take up? Excuse me. No. You are not audible.
The first issue is knowing the anatomy, knowing where you're supposed to go. It's quite something else altogether if you know where you're supposed to go and whether you can get there in the first place. Okay, so I think that's two separate issues here. With our tools that we have available, it's nice to know where you should hit to improve your success rates. Of course, I would like to know that. can I get there? Can I drill that far in? Does it really make any difference on the table? Does it change the outcome regards to whether it's a right bundle, left bundle, the area or block? There's so many unanswered questions there. And that's reflected in that kind of ECG morphology that we see time and time again when we implant it. But on a separate note, just a question really. Oh, do you have any idea why if you're not pacing close enough or that anatomical area that you want to hit for your his bundle pacing, why are the parameters okay on the table, but because it's distal to where you're supposed to hit it, why does the threshold goes up subsequently? Because the lead hasn't changed. It is the same position, yet the parameters were okay on the table, but progressively worsen over time. Do you have any idea anatomically?
Yeah, there are two things here. One, how we define acute success on table. The way we define success for his bundle pacing at the moment, we define it as at 1 millisecond and 2.5 volts. It could be very well, the acceptable parameters could be much less than that. So the acceptable parameters, what I mean to say 2.5 volt, which means if we get an acceptable, we accept some lead output at 1.5 as a threshold at 1 milliseconds, that were 3 patients who had failed, who had a threshold of around 2 at pacing, and we could accept it, and all of them were parahesian. What many see is a non-selective pacing. They were not selective his bundle pacing. So achieving non-selective on table, and though we define a successful parameter is less than 2.5 volts, a little higher on that range, all these patients had failed long term. Dr. Vijayaraman defines success again with his bundle injury current, and he defines success based on his bundle, which was not looked at, but then his injury current, he says these patients are less likely, or maybe they are not, they don't fail at long term as well.
Deep, the question was, why there occurs rise in the thresholds as compared to the deep septal pacing? I think it is the environment where you have screwed the lead, because this is after all the membranous structure, and hence the fibrosis around the tip is going to be actually a continuous process, whereas intramuscular the fibrosis is less of an occurrence.
So it really doesn't matter where the location of the lead is.
Yeah, if you are deep into the septum, the so-called there occurs probably some other kind of an insulation, but the element of the fibrosis there is much less. Here it is fibrotic structure, and then the fibrosis would continue. That's the mechanism that has been described. Yeah, that's one study. That's one study.
Exactly, because
Yeah, yeah, that's one study, and
if you have fibrosis, you're going to get fibrosis anyway. Why should the disease not there?
yes.
Does that mean in vascular area? I think that's what it is. Maybe in vascular areas, fibrosis is more likely to happen, and the further you are, you have more fibrosis. You don't know. Really, you don't know. Is there any way to quantify fibrosis?
Yeah. Absolutely. Absolutely. Yeah, you know what, this classic Lenegre's versus Lev's conduction system, that's the, absolutely, if you have Lev's, which is actually the calcification process, right, of the skeleton, I think you're right. If the etiology also matters with respect to the rise in the thresholds.
So Deep, if you were to think of reproducing the same imaging study in left bundle area pacing as to what depth and how close to the LV subendocardium gives a selective left bundle pacing or something like that, and since the parameters of the left bundle area pacing remain stable in the 6 months or 1 year studies, can't you better use an MRI for doing these studies, because the resolutions are going to be far better with an MRI than with the CT? Why insist on a CT?
As far as the, irrespective of MRI or CT, one fact that we are going to encounter is the lead artifact. And number two, I think CT is more accessible to the patient, and we are not, disregarding the radiation aspect. We are not using any contrast here. We are the patient goes in and comes out quickly. We are just having slices of the scan and then get it to the ECG, do the end diastolic, and study the end diastolic parameters. It was much simpler. We have not tried MRI. I do not know how MRI
What
would
slice
settle.
scanner this was?
This was 128. I think that's easily available as well, 128.
All right, Deep, thank you very
Yeah,
much.
thank you.
So now let's hear from the expert, Dr. Tan Bun. It was, like yesterday, seeing him in action had inspired so many. I told the abbot to have a large stock of the Agilis Pro. Everyone is going to be holding that tool. So we are all kind of grateful to Dr. Tan for inspiring all of us and be courageous to hold the tool. So in continuation with whatever he has been teaching us today, we again learn from him about CSP specifically in heart failure situation. If you are comfortable, you can remove your mask, please.
By many different speakers since yesterday, actually. They've touched in many different trials. So I'm just going to go through some of it, hopefully give an example as well, okay? And again, the earlier speakers has also gone through how CSP pacing can correct bundle branch block, per se, or conduction delay, per se. Okay, so I'm going to start with just a straightforward case, and actually I was going to use the left bundle branch block patients earlier, but we had a discussion yesterday about left bundle and normal conduction. So I'm going to try an example now with the right bundle branch. So somebody with a right bundle branch block, a gentleman, ischemic heart disease, EF 24%, multiple admission, full right bundle branch block, QRS about 180 milliseconds, intermittent 2-to-1 block, and complete heart block on ECG. Came in basically with recurrent syncopal events as well as near syncopal events. So objectives of this study. So what would you do with this patient? ICD goes in, CRT goes in. How do we fix something like that? What is the mechanism of this? Can we correct it with a his bundle? Can we correct it with a left bundle? That's more interesting here, isn't it? And if you do correct with the his, or if you do correct it with the left, what is the mechanism of correcting it? Now, knowing where it blocks, how it blocks, is just part of the story. The other part of the story is, how can you correct this? Is it that simple? Because knowing where it blocks just gives you the target where you're going to hit, potentially how you're going to correct it, but the mechanism, that's a different story altogether. So the mechanism is here, conduction system pacing, how you can correct conduction abnormalities. Now, the earlier speaker has spoken to you about longitudinal dissociation, and we'll go through that in a little bit. He also spoke to you about source-sink relationship, as well as a virtual electrode polarization. So we'll touch a little bit on that and how those mechanisms potentially can help us and where it won't help us, okay? We'll talk about his bundle in heart failure. Again, different speakers have gone through different studies, but we'll just touch a little bit on it, so you can fall asleep if you want to, that's okay. We'll talk about how left bundle branch pacing can also correct this conduction delay and how it's used in heart failure. Okay, so we know all the guidelines. Okay, everybody knows about CRT, QRS more than 150 milliseconds, got left bundle branch block, EF 35%, poor NYHA class, CRT goes in, class 1 indication, done deal. We know how it works, we know how to get the CS lead, that's it. But if you really think about it, what we're doing is pacing endocardially on the right side, and then pacing epicardially on the left side. Both in itself individually causes dyssynchrony. Okay, so in effect, what we're trying to do is put two dysynchronous wavefront, gel it all up together, and say, hey, we're going to fix 2 negative doesn't equal 1 positive. So that's really just an oxymoron statement, basically. And it is no wonder somewhere anything between 20 to 50% of patients with a CRT, well, it just doesn't work in the first place. Okay, how can you possibly have 2 negatives and give you 1 positive? It doesn't make sense to me. What we cannot answer is patient with right bundle branch block or patient with intra-bundle conduction delay. They do terribly with it. If you got left bundle branch block, it's not so broad, they do terribly as well. If you got high pacing threshold, and because you're pacing on the right side, causing dyssynchrony, it gets worse. And suddenly you tell me you paste the RV apex in the left CS, it's going to get better? Seriously? What about the right side? The synchrony on the right side. It's actually, we're just apathetic and ignorant about it. And the simple fact is this: we don't know how to do it. We can't do anything anyway. So why bother with the right side? Importantly, if we correct the right side, does it make any difference? The answer is it does, and there's mounting evidence for that. So how conduction system can overcome blocks? Longitudinal dissociation, we actually saw the first speaker was talking all about that. And basically, if you look at the photomicrographs of the AV node as well as the His bundle, you look at the AV node, it's actually where the collagen fibers are interweaving. It's actually very haphazard. But once you get to the His bundle, it's actually arranged longitudinally. And the idea being is that if you want to overcome this, well, just paste distal to it, right? It's a small proximal, paste distal. Is it that simple? Well, not quite, because blocks are not so simple. The blocks can also occur because of differential sourcing effect, and it took me quite a long time to actually go through this, but this is basic electrophysiology. But we just touch a little bit on that. Now, sourcing means that it's a little bit like a bucket. You got to have one big bucket pouring to another bucket, and if the second bucket, the sink, that bucket gets enough of a volume inside there, it becomes the next source, and that triggers depolarization on cells adjacent to it. And it is elegant in its simplicity. In other words, you will not lose the amount of action potential or potential from one cell to other, because the action potential will be exactly the same as it goes on. It just doesn't lose energy as it goes along downstream. But there are a lot more factors affecting sourcing effect, especially in disease myocardium. And it's basically a balance. How big is your source? How big is your sink? You can increase your source by increasing the inward current, so a big potential, okay, big voltage. And we see it all the time in conduction system pacing, isn't it? Well, low output you don't capture, high output selective, non-selective. We keep using the term again and again and again. This is basically giving you that potential. You got longer action potential. For example, in your source, you can initiate depolarization in cells proximal to it, distal to it rather. At the sink, the inward current, the outward current rather, the repolarization current can tell you, okay, because if you have low repolarization, it's less likely to depolarize from whatever source, however big that source may be. Gap. The amount of gap, how much resistance between cell to cell. So more disease cells, more resistance between cells, it won't be able to depolarize. Or the gradient. So if disease cells with a long gradient before it can depolarize, that can resist depolarization. Even the depolarization wavefront can influence whether that depolarization waveform is actually propagated. For example, if you got a linear, like the picture A down there, you get a source that is a flat, okay, it's one-to-one conduction, it's very easy to conduct. But if you get a depolarization that is a bit like a curve, a semi-curve, the source is a tiny bit right in the middle, but the sink is at one source, many sinks, many cells, and you can dilute it, it doesn't propagate so well. Okay, so that's another to keep in mind. So the cells may be conducting, but because of differential sourcing effect between your source and your sink, it may not conduct so well. And if we could get a lead there in conduction system pacing, we may be able to overcome this and still be able to propagate potential. There's also, and this is also mentioned in the earlier speaker, a virtual electrode effect. And basically, in virtual electrode polarization, you don't even need to be in contact with the tissue. You can have a tissue and cause a depolarization in close proximity to it. You can cause zones of depolarization as well as zones of hyperpolarization. In the zones of depolarization, it starts at propagation wave in make waves. But you don't necessarily have to have that. You can also have areas where depolarization, and you give enough of a cathodic stimulus to it. You can cause areas of hyperpolarization, and that can also cause a depolarization wave. In other words, I don't need to be distal to your conduction block. I only need to be close to it. I can also initiate depolarization, very much like if I want to defibrillate a heart. I'm not in contact with the myocardium itself. I can cause depolarization, well, in close proximity, if I give you enough power, right? We can actually do that, okay? So that's the idea in a very simplistic way, the virtual electropolarization. So how does the His bundle pacing correct this? Okay, so let's go back to the His bundle pacing. In patients with heart failure, specifically with left bundle branch block, believe it or not, the first study actually dates back almost 10 years, actually, by Dr. Baba Pichardo, okay? I don't know whether I pronounced his name correctly. Okay, basically a small study, only about 9 patients with left bundle branch block, put a His bundle there, able to correct the left bundle, in fact, dropped the QRS about 97 milliseconds, and that was associated with shrinking of the left atrial diameter, left ventricular end diastolic diameter, systolic diameter, as well as EF improvement. And small studies along the way. The biggest by far is by Dr. Sharma's group, and what they did was about 106 patients, broke it out into 2 groups. The first group was actually patients who were unable to do CRT, and it was a rescue. The His bundle pacing was a rescue. Group 2 were patients predominantly with pace-induced cardiomyopathy. And what they did was actually do His bundle pacing in these patients. And perhaps not surprising, with bundle branch block, you can actually narrow down the QRS, the 160 milliseconds, and the ventricular pace rhythm also narrow down the QRS complex. And no matter how bad is your EF, it's associated with an improvement in EF, as well as NOHA class. But it comes with a price. We all saw what happened yesterday when we were doing the case with the His bundle. The thresholds were a lot higher. With bundle branch recruitment to correct those bundle branch, but also came at a price, thresholds. You needed a heck of a lot more output to do it. And almost 7% loss or loss of bundle branch recruitment in the future, complications in the future. So that's the problem with His bundle pacing. Oopsie. What if His bundle cannot correct this? And the previous speakers from yesterday spoke about the hot CRT trial. Okay, and basically what happens is that you try to do a CRT system, the by-V pace doesn't correct it properly, down to about 162 milliseconds from 183 QRS. And when you try to pace the His, you can't narrow it any more than 150 milliseconds, and that's because there's distal LV conduction delay with patient with left bundle branch block. And what they did was put a CS lead in, and they can narrow that complex down to about 120 milliseconds. Now, basically, more fusion, the narrower the QRS, and we had this discussion yesterday as well, the more likely are you to get an improvement in your EF. And that's pretty consistent. LVEF improves, LV volume also improves, better NYHA class, and LV and diastolic diameter also improve. Now, granted, most of these studies are not long-term, they are coming to about a year to 2 years, generally. So what about right bundle branch block? Because when you have a His and a conduction system pacing now, you're not just correcting the left bundle now, you can also correct the right bundle. So is there evidence for that? Again, mainly small studies. Dr. Sharma's group, 39 patients. Again, His bundle pace, right bundle branch recruitment, in about 78%. What's interesting about this is that even if you don't have right bundle branch recruitment during His bundle pace, they can use fusion because they still have an RV lead. And they can actually fuse that by pacing the His without recruiting your right bundle and still pace the RV apex and cause fusion. Okay? And I'll show you the results of that. Again, it came at a price, higher thresholds, as well as loss of bundle branch recruitment. Now, not surprising, QRS does narrow with His bundle pace, and that's associated with overall improvement in LV function. But what's interesting is this, even with patients without right bundle branch recruitment, and if I can cause fusion, that means correcting the right side of conduction delay to a certain extent with the RV apical pacing as well as His bundle pacing, I can actually cause improvement clinically. So what about patients with pacemaker-induced cardiomyopathy? We know that pacing the RV causes dyssynchrony, and that dyssynchrony itself can cause pacemaker-induced cardiomyopathy. Now, again, this is Dr. Vijayaraman's study, and what they did was to look at about 79 patients, pacemaker-induced cardiomyopathy, a lot high pacemaker burden, 98% and above. And His bundle pace does narrow QRS, no wonder, because pacemaker QRS is 170, 180 milliseconds, of course. Ejection fraction does improve, and that's associated with improvement in functional class. But His bundle pace comes at a price. We all know that already. Area is small, scale, you can see even with Dr. Ulhas, we have to actually move the catheter around. The target is not easy to get to. Thresholds are high, there are sensing issues. Distal AV block, potentially you may need a backup RV lead. And if you need to ablate the AV node, for example, you be a bit worried about that. That's where the left bundle area pace comes in. Now, this is from the left bundle area collaborative study, and what they did was actually to use left bundle branch left bundle branch pacing in patients with heart failure. And what they did, they had about 116 patients, about 42% of the patients with left bundle branch block, and putting in a left bundle branch pacing lead, and pacing the left bundle area, managed to narrow the QRS. It's only about 130 milliseconds on average. And that was associated with improvement in MIHA class, ejection fraction, as well as end-diastolic LV diameter. But if, and we touched on this already, if the left bundle itself cannot correct your left bundle branch completely, we have something very similar to the hot CRT, and which was discussed yesterday, which is a lot CRT. So now you have a left bundle branch pacemaker lead there, pacing the left bundle area, but the conduction block is more distal. You put in a CS lead to try and correct that left ventricle conduction delay. And again, we touched base on this, but I just want to highlight a few things really. Number one, by VCRT, you see the QRS is about 170 milliseconds. Left bundle area pace managed to narrow it a little bit more to about 160. But look at the QRS in lot CRT. They only narrow it down to about 140 milliseconds. Yet, although it's still 140 milliseconds from the baseline 180, you have improvement in EF, improvement in LV volume, NYHA class, as well as left ventricular and diastolic diameter. But again, I won't go into too much details because that was touched on by the speaker yesterday. Left bundle branch, surprise, surprise, and I showed you an example yesterday of how you can influence your right bundle. It can also correct your right bundle branch. Now, we went through, I showed you this slide yesterday, and how it corrects is multiple waveform. You can have the left bundle branch activation because you entrain, you capture the left bundle, and you end up with a transceptor activation, very much like baseline right bundle branch block. Left bundle goes down, goes towards the right. You can have the deep septal capture on the left side, going down the septum, going back down to the right. You can have your anodal capture, going from the right septum, going towards the right side. Or you can have retrograde activation from the left bundle towards the right side. And often it's a combination of all of this in an attempt to correct the right side. So what is the evidence? Now, from the left bundle branch collaborative study again, about 107 patients had right bundle branch block, poor EF, again with pacing or CRT indication. Interestingly, look at the LVAD. It's only about 80. It didn't go anything below 80 milliseconds, where traditionally that's what we took. And there's improvement in NYHA class, but that came when your QRS didn't narrow all that much. In fact, it only narrowed on average about 10 milliseconds. Yet it had NYHA class improvement, had clinical improvement with it. Right bundle branch was only eliminated in 33%, but attenuated in 64%. And that was associated with almost 25% of super responders. So correcting right bundle, even if it attenuated, you can have good clinical outcome. And that is associated with patients who are female. And as I mentioned before, if you have a QRS duration, a shortening reduction of 10 milliseconds or more is independently associated with a better outcome. And you have to ablate the AV node. Okay, again, we're just going now with heart failure, patient with atrial fibrillation, you have to ablate the AV node, basically a pace and ablate approach. Is there evidence? Yes, and this is from Dr. Wang's group. Okay, and what they did was actually 86 patients with heart failure. Some patients obviously didn't go for AV node, didn't want the AV node ablation. And there's another group of patients who underwent AV node ablation, and they were subjected to conduction system pacing, be it a his bundle or a left bundle area pace. Perhaps not surprising, they're less likely to get inappropriate therapy because the AV node is ablated already anyway. Okay. And importantly, in group 2, where they underwent conduction system pacing after AV nodal ablation, it was associated with improvement in LVEF as well as LV and systolic volume. Again, not surprisingly, if you have left bundle area pace, sensing is a lot better, pacing threshold is a lot better with left bundle area pace. So coming back to our patients now, okay? This patient has a right bundle branch block, intermittent 2-to-1, horrendous EF, okay? How do we correct something like that? So anyway, this is what we did. It's a CRT system with a left bundle, just a left bundle lead putting in there, correcting and pacing the left bundle branch. So again, this is us putting in. We should gain that lead there, but you can see the left bundle potential there. This is anodal capture bipolar, and I just like to do this, okay, it's quite nice, okay. Anodal capture, bipolar, QRS down to about 120, 130 milliseconds. And you can see in lead V1, you get a QR pattern. You don't have the R, the big R in right bundle branch block already. And basically, we are correcting this to a certain extent because, as I said, there's anodal capture, there's non-selective left bundle capture, there's two wavefront coming towards the right. Baseline already there's a right bundle, and the left side is activated by the left bundle branch capture. So as we drop the capture down, I should correct that slide, it's terrible. Okay, to about threshold, about 1.75 at 0.4, you see there's a change. You see that? Now you have lost anodal capture. The R, when you lose anodal capture, you don't have the right bundle. The anodal side, you have lost capture already, but you got non-selective left bundle branch capture alone. Now you can see already there's a change there. The R becomes more pronounced in V1, and that's the baseline on the far right there. Similar to it, but yet it is narrower. Okay, why is that so? And that's because, and this is the ECG, so it's still narrower than the baseline, which is about 180 milliseconds. And that's because we have another wavefront now with the non-selective left bundle. That wavefront actually occurs on the left side, deep septum, and is activating the right side across the septum. So you can still narrow the right bundle that way. Now we try to pace from the RV call and see how much it contributes, because now, because I've got a defibrillator lead, I got a dual bipolar lead in that left bundle area, I can selectively just say I want to pace from the ring because it's a CRT system. And you can see that just pacing from the ring towards the RV coil, I can pace in the anode, basically in a bipolar in the anode. And you can see that it does correct the right bundle to a certain extent because now it's activating the septum on the right side, okay? And basically what's happening is that I get a wavefront coming like that, and we are correcting it to a certain extent. But if you pace on the RV apex, it just looks terrible. Okay, the QRS is 200 milliseconds. It's just horrendous. So pacing from the apex really doesn't correct this by much. But as we lower the threshold, as we do the threshold test, we end up with selective left bundle branch capture at an output of 0.75 at 0.4 milliseconds. Now you can see that it's actually dropping. And now what we are getting is that we're just capturing the left bundle alone as we drop the output, okay? That's sequentially and us going across the board. And I'm not bullshitting you. You can see that the QRS there, it jumps up. There's an isoelectric, and it just jumps up when you get selective left bundle branch capture. What's interesting is, again, selective left bundle branch, and the LVAD remains unchanged, okay? And what's interesting is the conduction system with selective left bundle is identical to the conducted beats. Exactly identical, okay? So in summary, for this patient, there's actually conduction delay in the left ventricle anyway. The LVAD was slightly long to start off with, okay? There's also RV conduction delay. But the RV conduction delay, because this is really right bundle branch at baseline. This was not correctable by local septal myocardial activation at the anode. It's corrected to a certain extent. It is also not correctable by retrograde conduction up from the left bundle towards the right, because the block is probably very proximal. Okay, so in summary, conduction system is a promising alternative. It's as a rescue strategy, especially in patients with non-respondent BIV, it's certainly something that we can try. Currently, as mentioned by previous speakers, there's really no large-scale randomized trial to compare. There are many unanswered questions. For one, is one conduction system pacing better than the other? Okay, what tells me his bundle pacing or left bundle pacings versus hot or lot CRT, which one is better? Is there any ECG indicator? Is fusion important here? How important is that? We don't have good answers for that. And what are the ECG markers? Okay, is the degree of narrowing, does it predict the outcome of conduction system pacing? So many, many unanswered questions. Okay? Thank you. What questions do you have?
In right bundle branch block with dilated cardiomyocyte, instead of pacing left bundle, why not to pace right bundle?
Yes, you can paste right bundle. So that's a $1 million
correct
question.
the right bundle widening, and left bundle is conducting normally.
Yes, correct.
So instead of pacing left bundle, you pace the right bundle.
You can. So a few issues. Well, if you look at anatomically, actually Paul Roux had a very nice model of the heart, where the right bundle is. You look at the right bundle, it's actually a very tiny superficial conduction. Trying to pace the right bundle directly, proximally, will not be so easy. But you can think about pacing it at the moderator band, because it comes down through the moderator band apically. So can we target that moderator band, and can we correct it? The answer is we have not tried it. Okay.
So,
Okay. The second thing I will add to that is that it depends on where that conduction block is. Because if you look at the left bundle, if the conduction block is very proximally and you place distal to them, it's a longitudinal dissociation idea. If you place distal to the conduction block, yes, you can correct that. But if that conduction block is distal, that means in the Purkinje, his Purkinje, because it's dilated myocardium, progression of myocardial disease, for example, I can paste all I want in the septum. It's not going to correct. I think the same would apply with the right bundle. Now, whereas the left-sided, I can put the CS lead and we can correct it to some.
Already conducting normally, so by doing left bundle pacing, how you correct the right bundle?
Exactly. So that's why I gave you the initial slides. The left bundle can actually, to a certain extent, it's not directly correcting it. The only way you can directly correct it is that there's a retrograde conduction back the AV node and coming back down, because we know it can. In fact, yesterday, I don't know whether you were here, I gave you slides, a set of slides. I can show you that slides again. A patient with left bundle branch block, and we pace it with both left and right conduction delay. And I got a patient with normal conduction and how the right side is engaged. I can go through that again, but I think everybody saw that set of slides already.
so yeah, go ahead.
So sorry. You see, your question in left bundle branch block, selective or non-selective left bundle pacing is acceptable, and in the right bundle branch block, selective right bundle branch pacing, why it is not considered, right? It's only because when you do left bundle branch area pacing or a selective or a non-selective left bundle pacing, you are recruiting the right bundle almost instantly in 20 to 30 milliseconds. But if you pace the right bundle branch in a right bundle branch block, you actually cause a left bundle branch block, because the time that is taken to recruit the left bundle is significantly long. No, but the site where you pace in the right bundle, for example, if you're asking for the moderator band or proximally, I mean, the time that is required to recruit the left bundle is significantly long when you do a selective right bundle pacing. That's simple. In a left bundle, because you are in with a close proximity of the bifurcation of the conduction system, you would be able to recruit both the bundles almost simultaneously. And then
So that you can correct the intrinsic conduction through the left bundle and right bundle, you pace earlier, so that you can correct, become narrow.
And vice versa.
Okay.
And vice versa. And I will show you the versa here in a little while. In our patients with the left bundle branch block, how there's also right bundle conduction delay, and how I use the AV nodal conduction to come down to help us correct that. I don't think it's you want me to go through that set of
maybe, yeah, it makes sense to.
That may help you understand that you can apply both ways. Okay, so you can use that both ways to compute. So both of you are correct, because it all depends on the level of the block. Where is your block?
So one small comment. So simple answer to his question is that right bundle branch block per se, if the left bundle conduction is normal, will not cause heart failure. So just pacing the right bundle branch is not going to help. The pacing will only help if you, in any pacing, left bundle pacing or CRT will only have help in heart failure if you have additional left bundle branch delay.
So the answer is yes and no to that. If you're correct, by and large, it's associated with left bundle branch block, associated with heart failure. But it'd be naive of us to say that all patients with right bundle branch block will not have left-sided conduction delay. Okay, I don't think that is a correct statement.
No, I didn't say that. I said if the left bundle is conducting normally in a patient with heart failure who has right bundle branch block, pacing the right bundle branch will not resolve the heart failure. That's what I mean.
That's not the issue. Those patients having RBBB and LV systolic dysfunction, their prognosis is worse as compared to LBBB with LV systolic dysfunction in dilated cardiomyopathy. So RBBB.
But it is not because of right bundle branch block.
That our right bundle branch block has not caused the LV systolic dysfunction. It's the conduction system defect which has.
So many of these patients actually have left-sided conduction delay also, which is not manifest on the surface ECG. And that's how some patients benefit. And just correcting right bundle will not help a patient with LV systolic dysfunction. So we have to see the context in which the pacing is happening, whether.
You have to narrow.
I know, no. Yeah, exactly.
I think we're jumping a little bit, okay? So when you say correct the right bundle, if you did correct the right bundle, did you actually also correct the left bundle in the process?
Right.
Okay, that's the million-dollar question.
Yes.
Vice versa as well. If you correct the left bundle, you potentially can correct the right bundle to a certain extent. So how do you actually break that? Okay, can you separate one from the other? My answer is I don't know how to do that.
Correct.
Okay, I don't know. I'm trying to.
Yes.
I'm trying to tell you that, look, is it just sufficient to correct left alone or right alone? All I can tell you is that often it's not as simple as you think it is. Because you can't correct one without the other. The other will be influenced to a certain extent. How much you influence will determine your outcome. How well you can influence that. Okay, so I don't have a good answer for you. In fact, dinner last night I asked Dr. Hongo the same question. How much correcting the right bundle is likely to correct your LB? How much is contributing to it? We don't have a good answer. I asked many people that question, the exact same question you asked me. Does it make a difference if we correct that? Before, nobody ever looked at it because there's no way to correct it anyway. Who cares? So that's nice, right? We can't do anything about the right side. But now we can. Maybe this is time we answer that question. If we correct that right side, how we want to correct that? Be it the his bundle case or left bundle case. Even if we don't correct it, if we could attenuate it, and the evidence that even if we did attenuate it, we can have good outcome. Does it mean we should look at heart failure from a different perspective now? It's not just LV failure anymore. It's IV failure. It's not just left bundle conduction delay anymore. It's left and right bundle conduction delay. We have to look at it that way. Maybe that's how we should look at it. Maybe that's how we can improve our CRT responders from just a miserable 60 to 70% to something hitting 80 to 90%, if not more. Okay, I'll add after that.
Dr. Tan, I'm happy I presented lot ICD in this symposium. I think these right bundle heart failure are typically lot ICD candidates because one of your lead does the left bundle pacing and the second lead you have a DF lead which will synchronize the RV pacing. Now when you're doing a LV synchronization, you have a lead in the CS where you're synchronizing with the free wall. So my question is, do you have a choice as to where would you put your DF lead to synchronize it the best? Are we ready to take this to congenital hearts?
Okay, so the answer is yes, you should on your LV. The QLV still works, but the QLV then, this situation will be your QLV from whatever branch you choose and your left bundle case.
No, I'm not asking QLV. I'm saying, do you have a choice where you will put your DF lead in the RV? What location? Because you want a free wall pacing to synchronize the best, and of course in RV you can't do a free wall pacing.
Don't have a good answer for that other than more pragmatic answer. Because you're a call, you got a small heart, go into the apex and make sure the call is in the RV, that's it. Okay? I've thought about it as well because practically speaking,
If you do in the apex pacing, your pacing just distal to your right bundle. So will it synchronize more than?
The answer is potentially it can. Remember, the Shah once we go with the his bundle and you're causing fusion, you potentially you can. And one of the explanations, and I can't prove this, okay, is that if I pace at the apex, I'm closer to your moderator back. Okay, so which one is closer to moderator? Is the left-handed anodal capture closer to your moderator back, or is my RV apical pacing closer to the moderator? That's assuming your moderator band is still intact in the first place. It's not disease and output when you have a right-handed branch block. Okay, so I don't have the answer for you. Okay, suffice to say, nobody's going to put the lead outside the pace in the right free wall.
That's right.
If there's connection there, it's just rooted. Nobody's going to do something like that.
Yes.
I have one more question. Can the technology advance so that IC release becomes left bundle pacing?
Okay, I'm not supposed to say that, but the answer is yes. I will tell you which company is working on it either. There is a company working on it. So I won't tell you because you got a non-disclosure clause that
It's
you
coming
got
up
to
or
sign.
it's produced already?
No, it's coming up. There is a company working on it. There is.
That's for the next.
Yep. So we were part of a study called Lead Art Study, which is still ongoing, but it's already that the concept and design is already out. So the Lead Art Study is specifically dealing with this, an active screw lead with the 4.7 French defibrillator lead, a long coil, and but whether or not you use that lead for it's possible to use it for left bundle branch pacing. Yes.
So if you want to have a look at the left other sets of slides again, I can go through it with you. Maybe that will help you explain this a little bit better if you want to.
No, we will have a talk on
Sure.
that.
Yeah.
Yeah, so I just was wondering, is the audience okay to listen to Pugal's one great talk before we break for coffee, or you want to have a coffee first? Huh? Okay. I think such choices should not be given. All right, so
So how many talks to go?
it depends on your interest. So you know what? We have at least three talks which are recorded.
चलो एक करा दो.
अभी करते हैं एक. फिर coffee. Thank you. So I think it's a tribute to the master conduction system pacer, and that is our own Vijayaraman Pugalindi. Well, you know, I think many of us have heard his talk.
How do you say Pugalindi?
Pugalindi. And you know, I think he wouldn't mind if you make it even more abbreviated. If you say Pugal, I think it's also okay for him. So I know it's a tribute to the master, and we all respect him. And you know, I think he also created our own star, Shanmuga. I think Shanmuga had collaborated so very well with Pugal that, you know, there's so many publications. You know, we are very proud of both of them. And every time Pugal had come to India, I think we took his help to shape our CSP program in our own institute, and I'm sure he had been to some other centers. He had been here 2 occasions. One of the symposia and another one was the launch of the deflectable sheath of Medtronics. So on behalf of all the members here in the symposium, I thank Dr. Pugalindi. He was very busy actually, and then still he made some time, and he had sent us his video recorded presentation. So it's a privilege to hear Dr. Pugalindi.
Been asked to speak on the evolution of conduction system pacing, which is somewhat a long topic, but I would like to congratulate Dr. Pandurangi for organizing this wonderful symposium. These are my disclosures. It's well known that right ventricular pacing is a form of desynchronization therapy, both resulting in acute and long-term changes. And we also know that right ventricular pacing, more than 40%, and in some cases more than 20%, can lead to increased risk for pacing-induced cardiomyopathy. In various attempts to use non-apical pacing, either outflow tract or RV septum, over the years have resulted in mixed findings, and in some patients, maybe non-apical pacing may be associated with better outcomes. However, there's been no marked differences in survival or quality of life over the years on a meta-analysis. And very importantly, this very large study, BioPace, comparing RV pacing versus IV pacing in patients with AV block, did not show any significant difference after a very long study in heart mortality or heart failure hospitalization, even in patients with low ejection fraction. So over the years, conduction system pacing, since the initial description by Dr. Deshmukh on patients undergoing AV node ablation and subsequent multiple reports utilizing specific catheters and leads, predominantly a 3830 lead, suggested that conduction system pacing may be feasible. However, it didn't translate into widespread acceptance. Nonetheless, conduction system pacing is the most physiologic form of pacing, as conduction occurring through the native His-Purkinje system can prevent pacing-induced dyssynchrony, and we can achieve AV and VV synchrony at the same time. And early on, we had demonstrated that using His-Purkinje pacing compared to right ventricular pacing, a significant difference in the overall clinical outcomes of showing that you can improve mortality and heart failure hospitalization. And that was the early experience showing that His-Purkinje pacing in all comers is feasible. Subsequent studies by Dr. Wang's group in China also demonstrated that if you pace the lead slightly more distally and using two-lead technique to identify the optimal site, then you can achieve better success rates as well as improved electrical performance. So now we know that conduction system pacing can be used to not only maintain synchrony, but also restore synchrony in patients with underlying dyssynchrony in the form of left bundle branch block, right bundle branch block, or IBCD. And the type of pacing is determined predominantly by the site of block, conduction disease, and acceptable pacing parameters. So that has led to the utilization of His-Purkinje pacing and the new form of pacing called left bundle branch pacing, or LV septal pacing. Now, our understanding of anatomy of the conduction system also has helped develop these new approaches with newer tools, and this has taught us how to target the proximal conduction system in the AV node versus the left bundle and His-Purkinje region. And further, physiologic studies like this one from Dr. Tang showed that in majority of the patients with the left bundle branch block, the block lies at the site of distal His or in the proximal left bundle branch. It also helped us identify the IVCD patients where the septal activation, Purkinje activation, is quite intact, where conduction system pacing may not provide additional improvement. As you can see here, left bundle branch block can restore conduction through the His-Purkinje system, as shown by mapping on the septal side. Similarly, left bundle branch pacing also can restore conduction across the left bundle branch region, and thereby improving clinical outcomes. This is an elegant study from Imperial College comparing His-Purkinje pacing versus biventricular pacing, showing body surface imaging using ECG, showed that the QRS duration, LV activation time, left ventricular dyssynchrony index were significantly improved in patients undergoing His-Purkinje pacing compared to biventricular pacing in left bundle branch block, resulting in greater hemodynamic improvement, suggesting that you can achieve maximal electrical resynchronization with improved mechanical performance. Similarly, here is a nice illustration from a case study showing abnormal activation using left bundle branch block and complete normalization of LV activation using left bundle branch pacing. And this is, shows you the clinical, let me see if the videos will play, showing the activation patterns during left bundle branch block and during conduction system pacing utilizing left bundle branch pacing. And here is another study using left septal pacing endocardially and hispanal pacing in patients with left funnel branch block, showing that body surface mapping using ECG imaging, the hemodynamic effects and electrophysiological effects were better in patients undergoing hispanal pacing, and these effects were similar with left septal pacing compared to biventricular pacing. So left funnel branch area pacing may provide similar electrical and hemodynamic benefits. Over the years, we've also able to get better tools, predominantly the Medtronic C315 and C304 his sheets, and 3830 leads were the ones used. Now we have a variety of different shaped sheets from different manufacturers, allowing us to target both his and the left funnel branch area using both lumenless lead and Stylet driven leads. This has led to an explosion of information and more science being published almost on a daily basis. If you look at methodology, we also learned over the years that three-dimensional mapping can improve success of the hispanal pacing and reduce fluoroscopy durations. As you can see here in a patient left funnel branch block, you can identify the sites of funnel branch correction and successfully place the leads using a mapping system. And this approach can also be used in patients with complex congenital heart disease, like in this patient with corrected transposition. His region was successfully identified and excellent non-selective hispanal pacing was achieved in this patient. Again, similar approaches can be used to target the left funnel branch region, especially in patients with conduction disease and in patients who have underlying congenital heart diseases. This patient with a repaired interventricular septal defect. And while initially his bundle and electrical mapping was helpful in identifying the target site for his left funnel branch area pacing, subsequent studies have demonstrated that you can use just fluoroscopic and anatomical approach in targeting the mid-septal region as shown by this 9-partition method. Or you can use similar approach but using a tricuspid valve ventriculogram and identifying the putative hispanal region and subsequently targeting the region where you assume the left funnel branch would be. And we also come up with better evidence of using PVC induced during lead placement to help us guide the depth of the lead placement. By looking at the shape and morphology of the PVCs, we can get to the left funnel branch region very quickly and stop as soon as you achieve this narrow, complex PVCs that simulate the left funnel branch area pacing. And other efforts have been used to combine conduction system pacing and LV pacing in patients with complex mixed conduction diseases. In this patient, you can achieve better electrical resynchronization by means of heart CRT. Similarly, combining left bundle branch pacing and LV coronary sinus pacing can further improve electrical resynchronization, as demonstrated in these two studies. Both heart CRT and LART CRT resulted in incremental improvement in QRS duration when you combine conduction system pacing with LV pacing called heart CRT or LART CRT. And we've also learned more data regarding clinical outcomes of using conduction system pacing in bradycardia. You can see this was a single center study comparing two hospitals with hispanal pacing versus RV pacing. And similarly, this is a two health system study using left funnel branch area pacing versus RV pacing in bradycardia indication. The need for upgrade to bi-V pacing or the incidence of death or heart failure hospitalization was significantly reduced in this group of patients with physiologic pacing. We also learned that comparing non-selective versus selective hispanal pacing, there was no significant differences in clinical outcomes, suggesting that non-selective pacing may be as good as selective hispanal pacing. And this is a smaller study using 359 patients with hispanal pacing compared to left bundle branch area pacing in bradycardia indication that the primary outcome of death or heart failure hospitalization was not significantly different between the two approaches, suggesting either approach, depending on the need, may be adequate for preventing adverse outcomes. And recently, we looked at our experience in patients undergoing cardiac resynchronization therapy. The incidence of death or heart failure hospitalization was significantly reduced in those who underwent conduction system pacing compared to biventricular pacing. And this outcome difference was even more pronounced in patients with pure left bundle branch block, as defined by Strauss criteria. And we also demonstrate that in patients with advanced conduction disease, heart CRT or large CRT can result in improved LV ejection fraction compared to baseline. And this is all these explosion of studies have led to initial clinical trials, as the HIS-SYNC and HIS-ALTERNATE study was performed using hispanal pacing versus bi-V pacing, showed equivalent benefits of hispanal pacing compared to biventricular pacing. This was somewhat plagued by a higher threshold to correct left bundle branch block, as well as higher crossover rate due to lower success rate, varying from 50% to 76%. And recently, Level AT trial also showed equivalent, in some cases, superiority for decreasing left ventricular activation time compared to biventricular pacing with conduction system pacing. Similarly, reverse remodeling, hospitalization, and functional class improvement also was non-inferior to biventricular pacing with conduction system pacing. And recently, left bundle branch pacing was compared with biventricular pacing in a smaller randomized clinical trial, 40 patients, showing left bundle branch can be associated with superior LV ejection fraction improvement compared to biventricular pacing in this population. And another crossover randomized study of hispanal pacing versus biventricular pacing in patients undergoing AV node ablation and reduced ejection fraction showed greater improvement in LV function utilizing hispanal pacing in the setting of AV node ablation compared to biventricular pacing. So where do we go from here? Currently, our guidelines suggest a class 2A and 2B indication for hispanal pacing in certain clinical scenario of reduced LV function, and ESC guidelines have given hispanal pacing in the setting of AV node ablation as a class 1 recommendation. And as a result of all of these studies, the electrophysiology community, especially the Heart Rhythm Society, APHRS, Latin America Heart Rhythm Society, have worked on releasing new guidelines for cardiac physiologic pacing for the avoidance and mitigation of heart failure. These guidelines are under review and expected to be released early next year. And furthermore, in order to bring physiologic pacing to the forefront, we have several clinical trials undergoing both in patients with LV ejection fraction greater than 50% and in those with LV ejection fraction less than 35% and the intermediate group. And all these clinical trials hopefully will deliver the result that will guide us to where we should place physiologic pacing in our pacing armamentarium, both for bradycardia and cardiac resynchronization therapy. And thank you for your attention.
See, one of the reasons why we organize these symposia is just to get the young electrophysiologists to embrace this technology and somehow inspire them to work harder. And that's what the industry also likes us to do. Each symposium, we kind of conduct certain online questions and they in the form of the quiz. And this year also, we have chosen some 10 brilliant youngsters who really had done well with the online quiz. And it's my privilege to get again Dr. Tan here over the dais. You have inspired not only the seniors, and I think you inspired the juniors the most. And they have been here for the last 1.5 days, and they have done well to get the golden pass. We had organized kind of an online quiz. They did very well, and we selected 10 youngsters, and then we sponsored their whole trip to this symposium. And now, this time, something special has happened. Dr. Amaya Udayavar, when he passed his DM, he came over here and he was exposed to the electrophysiology, what it is, and now he becomes one of the finest of the electrophysiologists of the country. He's not here, but then he tried to express his gratitude to our institute, and he would like to be a part of our, I mean, he of course is a part of our team even now, to reward these youngsters who had done so very well in that online quiz and who got this golden pass. He actually had bought 10 textbooks, okay, from his own pocket. And he carried himself all those 10 books. He's not here. He's not here. You know, actually, I was so touched when he was insisting. I said, I will buy it on your name. No, he said, I am going to be sponsoring those books. So Dr. Tan, would you mind coming over the dais and hand over Amaya's priceless gifts to the stars of the EP community now? Please come over, and yeah, I would start calling upon those stars one by one. Dr. Ankur Gupta, you can come. And yeah, so Dr. Tan, you can be there at the center. Ankur, you go and receive, and then you stay back, we can have a group photo at the end. Yes. So this is Dr. Ankur Gupta. And we have Chandra Banu here. He's not here, right? And who's the third one? Mayank, Dr. Mayank. Yeah, no, you stay back and we'll take a good photo, please. Yeah. Yeah. So Mayank, you are from PGI, right? Yes, sir. Yeah. Dr. Ankur also. You can be staying there. You know, stay there. And we have Bright Ujjwal, you know, the mentor of who is none other than our Karthikeya. Karthikeya, I mean, every year you give rise to stars. You know, one of them is Ujjwal. He's from Medanta City with Dr. Karthikeya Bhargava. And we have Bhushan Shah. Yeah, you can all stay later. We'll have a picture. Bhushan Shah, you are from? Okay. Now we have Jyoti Vijay here. Jyoti Vijay is not around. And who's the other one? Sai Kiran. Sai Kiran is around? Sai Kiran is not there. Okay. Then who else is there? Vishal. Dr. Vishal. You know, we are very few here. You know, my dais is quite big. So how about all the faculty to please join at the dais, and then we take a picture. Karthikeya, Deep, Ashish. Please come, Suchit. Everyone, you know. And India, if you are not there, you know, there's no fun. Come, please. Come. Oh, yes. Vignesh, you can also join us. Come. We take a picture here. And you know, you people be ready. Once this is done, again you can join if you want.
just 5 minutes later, just 2 minutes later, I'll call him.
So, Anindya, you know what? This would be the right place.